Hello, my name is Dr. Monica Flores. I am a pediatrician in South Florida, and I have been in practice since 2001. I am going to talk to you about evaluation and management guidelines. These guidelines have been changed and revamped and are going to become effective January 1st, 2021. This is my take from a general pediatrician standpoint. I think it can be used in general practice for internal medicine and other generalists, family medicine, etc. I am not a coder. I am a general pediatrician with an interest in coding and an interest in being paid by the insurance company for the job that I do. The information obtained in this presentation came directly from the AMA. I also attended a few coding conferences and tried to assimilate all the information into one PowerPoint presentation that I hope that you will find helpful. First and foremost in coding that has not changed from previously is that we can either continue to code by our medical decision making or we can code by time. We do not have to meet the criteria of time for medical decision making and vice versa. You meet one or the other, whichever one gives you the highest level of service for what is documented in your note. In medical decision making, documentation is also key, but it's a different type of documentation. Now we're establishing the diagnosis and we're assessing the status of these diagnoses. We want to start to use key words, things like chronic, stable, worsening, exacerbation, etc. And then we also need to take into account the management options, so medications, tests, discussions with the patient, or any other conditions that are affecting the care. When we code by medical decision making, the table stays the same. It's still problem, data, and risk, and we are still meeting 2 out of 3 of these criteria. So either problems and data, problems and risk, or data and risk. So you only have to meet 2 out of the 3 in order to pick the highest code that you meet the criteria. In problems, the problems are the number and the complexity of the problems that are addressed at the encounter. So those are your diagnosis, your colds, your asthma, your high blood pressure, and then any comorbidities that affect your medical decision making. So if you have a child with a cold and cough and they also have asthma, then you're addressing that asthma, start the nebulizer treatments if then that comorbidity directly affects your diagnosis and should be included. And if another provider is managing those comorbidities, you have to kind of address why you are putting your input. So if you have the pulmonologist involved in the asthma management, what is your opinion? What is your during that encounter? And then referrals, same thing. Why are you referring to the pulmonologist? What is being ruled out and what is being ruled in? At data, we're looking at the complexity of the data that was reviewed, either tests that you yourself personally ordered or tests that you reviewed from a specialist. If you're reviewing consult notes, document exactly which consults, what date, and maybe even a small summary of that consult note. So cardiology visited on July 2020 and showed PFO follow-up 6 months. Also, if you're interpreting tests that were not done in your office, document what tests, glucose metabolism, so glucose, hemoglobin A1C, insulin done by the endocrinologist on January 2021, completely normal, and the date. And then if you discuss options with other providers that are outside of your practice, that is also something that can go towards data. The most important thing, not only for pediatrics, but in my opinion, even family medicine and internal medicine, general medicine, getting information from someone other than the patient. So if wife comes in, if mom comes in, daughter comes in, and they give you information about the patient, then document that the historian was not just the patient, but who else was giving you information during that visit. It's going to be very important. And risk is either the probability or the consequence of the event. And it's based on the consequences of the problems addressed at the encounter and appropriate treatment for those problems. It includes medical decision making related to starting treatment, but also in testing hospitalization or in deciding not to start treatment or withholding treatment. All of those can pertain to risk. So this is the table that needs to be in your head, easily obtainable. And obviously by January 1st, 2021, not all of us are going to have every single one of these things memorized, and we're not going to be able to switch from one type of coding to another. So my suggestion is that you find this table. You can easily find it online. So breaking it down, biggest thing with this is that in the past there was a 99201 and a 99211. That one is completely gone. That code is no longer being used. Everything has been starts at 99202 and 99212. For those of you who don't know anything about coding, 02 is new patient and 12 established patient. And the biggest thing is they both have to meet this criteria. And we're going to pick the highest 2 out of the 3 in problems, data, or risk. So when we're looking at problems in a 99212, we're looking at one self-limited minor problem. So this is defined as a problem that may not even require a doctor, but the patient comes in. So they come in, they say, hey, what's this bump? Oh, it's a wart. That's a 99212. So it's a very minimal problem. It runs a definite prescribed course, and it's transient, not likely to permanently alter the health status. And it doesn't really have any comorbidities. No additional testing is needed. And the treatment is just palliative. You watchful wait, you gargle, you rest, you bandage, your dressings. Honestly, in my opinion, there's very, very few times that children especially, and probably even more so for adults, come in with just one tiny little thing that you tell them to do nothing for. Most of our patients are going to fall into 99203 or 99213. So these are, again, you have to meet criteria from either problem or data or risk, or problem and risk. So you meet 2 out of these 3 criteria. And the important thing with this is if you have 2 or more self-limited minor problems, you've already met the problem part. Or if you have one stable chronic illness, or if you have one acute, uncomplicated illness or injury. The biggest thing for me, I think, is that self-limited minor problems and acute, uncomplicated illness or injury, sometimes they flip-flop. A wart can be a self-limited minor problem if you do nothing for it. But if you say, yes, that's a wart, you know what? We could try some cryotherapy here, but he's 2, so he's going to cry and be upset. You could go home and try some compound W on that wart, put on duct tape and file it down, etc. And you told them to do something for it. You've told them to address it. It went from self-limited minor to an acute, uncomplicated illness. So that's important to know that depending on what your intervention is, a problem can fit one criteria or the other criteria. But for definition purposes, according to the AMA, a self-limited minor problem, it may not require a doctor or a health professional, but it is cared by us, and then it runs a definite and prescribed course, and it's transient, not likely to permanently alter health status. Whereas an acute, uncomplicated illness or injury is a recent or new short problem with a low risk of morbidity in which treatment is considered. So that's the biggest difference. A self-limited minor problem, you pretty much do nothing, whereas an acute, uncomplicated illness or injury, some sort of treatment is prescribed and documented. Really important. A stable chronic illness is an illness that lasts at least a year to lifetime. Doesn't matter the stage or the severity changes, so it could be in control, and it's stable if it's the specific treatment goals, the individual patient goals are being met. If the treatment goals are not being met, then it's not stable. This is where, like a BMI, so if you've addressed a BMI greater than 95% and the patient has eliminated chips and soda, and maybe they've maintained weight or lost a pound, then that is a stable chronic illness. But if their BMI was greater than 95%, they're still not eating healthy, they're still not exercising, their weight is increased, it doesn't meet the criteria of stable chronic because their weight is increasing. So the illness would have to be controlled. In data, you have to meet criteria from either category. And again, this is another reason why I think most of our visits are 99213, because most of our histories are assessments by independent historians. So you either have to meet the criteria in testing and documents, which is any combination of 2 out of the 3. You either review notes from external sources, not from your own group, which is different from the past, or we review results of a test, or we order a test. And it's important in the data, they're looking at each unique test. So if you do 2 tests, that counts to 2 data points. But most of us, as long as we document in the note history obtained from the mother and child, then for most all our visits, our data points are going to be met. So now we just have to make sure that we meet it either in a problem or in risk. In risk, there's very little low morbidity. You do some over-the-counter things. You do physical therapy, occupational therapy. And amazingly enough, a 99213 for risk is if you decide on minor surgery. So if you refer to the ENT and you say, refer to the ENT, discussed bilateral laryngotomy tubes, discussed adenoidectomy with the family, you've met the criteria for risk. A 99204 and a 99214. So this is a little bit more difficult, in my opinion, now to meet as general pediatricians, but it doesn't mean it's impossible. We just have to be aware that it's out there and what we have to do in order to meet it. So we have 1 or more chronic illness with exacerbation. So if you are seeing an ear infection child follow-up, and you also know that you're following that family for healthy living, BMI 95%, and you address it in your office, that's a chronic illness with exacerbation if that child has increased weight, it hasn't improved, etc. Or 2 or more stable chronic illnesses, or 1 undiagnosed new problem with uncertain prognosis. Everybody always says breast lump, but the other things that you can think of here is headache, and that you're thinking of doing a workup. You're worried about a brain tumor, or you're worried about severe migraines, so you don't know whether it could be one or the other. Abdominal pain, and you're doing a workup. You're ordering labs, you're ordering an ultrasound, you're ordering an x-ray. Those are undiagnosed new problems with uncertain prognosis. Or 1 acute illness with systemic symptoms, or 1 acute complicated injury. So again, you have to meet the criteria in either problems, data, or risk, but within each of these criteria, there's a whole bunch of ors. You don't have to meet every single one of them. You meet 1 of those, and then you've met that problem. So in data, you have to meet the criteria from 1 out of 3. And this is, again, where it becomes more difficult, because now that independent historian is bundled into tests and documents. And in there, you have to combine 3 out of the 4. So you review notes from an external source. You review the result of each unique test. So again, if you have a CBC, that's 1 unique test. If you did a TSH and a free T4, those count as 1 unique test because they go towards the thyroid. If you do a glucose, hemoglobin A1C, and insulin, those go towards 1 unique test. So each of those unique tests that are reviewed give you 1 point there. If you order a test, so you order a hemoglobin A1C, insulin, and thyroid, then that is a data point for tests and documents, or your assessment requiring an independent historian. Or if you independently interpret a test performed by another provider, so in the consult note from the endocrinologist, you review with the family the meaning of that increased insulin, then that goes towards data. Or you discuss management with an external physician. So you're sending a patient to the hospital, to the specialist, and you call them, you communicate with them, and that goes towards data. Now, this communication does not necessarily mean it has to be same day. So on these, when we were talking about time, it had to be a communication done the same day. But maybe for this one, you put a phone call into the nephrologist, review the case the next day. As long as you document it in the note and you don't close your note until you document that you reviewed, you can still give yourself credit in the data section. And then in risk, it's if you're giving a prescription drug, if you're requiring, if you're doing decision for surgery with patient risk factors or major surgery without risk factors. But the biggest thing in risk that's new is these social determinants of health codes, these Z55 and Z65. And these are really important for people who are also doing like medical home and things like that. These really need to be included in our notes even starting now. These are problems with education, employment, housing, economic adjustments, parenting, etc. We discuss these things all the time in our office. We discuss about the second grader who's not understanding multiplication. We discuss the reading disabilities. We discuss the inability to focus and attention. We discuss the fact that they can't get their medicines. They don't have a car. We just don't document it. So we need to start getting into the habit of documenting everything that we do. 99215, if you're doing this, you're also praying. So this is one or more chronic illness with a severe exacerbation. People who are in respiratory distress, they're septic, they're dying in your office, or an acute or chronic illness that poses a threat to life or bodily function. Again, you have to meet 2 out of the 3 in problems, data, or risk. So if you have somebody in the process of almost trying to die in your office, and you then meet in the data category, then you can get a 99215. It's hard to meet it in the risk category because the drug therapy, they're talking drug therapy requiring intensive monitoring for toxicity. You're looking at testing them quarterly, and they're looking at doing labs and physiologic tests or imaging in order to do this drug therapy. And I couldn't think of anything that I do in general pediatrics that requires that level of monitoring. Decision of elective surgery with the identified risk factors, or decision regarding major surgery, or a decision not to resuscitate or to stop care. I've only had to do that one time in my office, thankfully. It does happen, but it's not often. So in my opinion, for 99215, you're going to either meet it in problems or in data. And again, in data, now you have to add the criteria from 2 out of the 3 in either testing, independent interpretation, or discussing management. So for data, you're going to have to discuss the management with another provider, which is going to happen every time you're transferring someone to the ER, or also qualified health professionals. So even if you don't call your ER, your hospitalist or anything, you're talking to your EMS transport people, they're qualified health professionals. So that, just as long as you document that, it's going to be counting towards your data. But then you need to meet the criteria and the testing 3 out of the 4. Reviewing a note from an external source. So if that kid who's crumping from his asthma, you looked over the last pulmonology consult and you noticed it was 1.5 years ago because he hasn't gone, he's been non-compliant with his medicines, that would be one. Reviewing any results of a unique test, or ordering a test, or an assessment requiring an independent historian. So this is my personal take. I took the AMA's medical decision making, I put in my own information. I have it as a Word document. I've made copies of this, kind of getting ready for January 1st, looking things over so that we're ready when our office transitions over. I also have the timing codes. So I made, again, this is just an easy Word document. I put up the codes for the time. I put in the definition so that our providers remember what meets the criteria for time. And then I put in all the definitions along with some examples of what things would fit where. Again, so it just triggers those memory points. And then I also Googled some social determinants of health, pulled them up, and they're going to be available again for our providers in our practice so that we're ready for January